Okay, we're live. Hello, everyone. I am Dr. Vyvyane Loh from VLMD Rounds. Just wanted to say hi and provide an opportunity at this live Q&A for you to ask questions, to make requests, and just, chat a little bit if you want about metabolic health. And, it'd be great if you just introduce yourself as well. I think you can do that with the chat, yes, and put your questions or comments in the chat if you have any. I just want to point out too that several of you have requested topics, so yay, and I am working on them. I probably won't be able to get to them immediately, but I've made a list, so I have not forgotten. I just made an episode today, my first request, so I'm just counting them down, and we'll get to all of them, I promise. The way I make these episodes, I do all the content myself, and I film on my own. Usually after work, I finish at 9:30 at night, and then I try to stick it in there if I can. Otherwise, I have to do it on weekends, which are even rougher for me in terms of schedule. But, we get it in there. In the earlier episodes, tried to just do everything from my head. And then I started to make little notes and have just little cheat sheets around. And they're mostly bullet points. Talk about this, mention that, don't forget this, and when I'm thinking about an episode, I try to organize my thoughts around what I want to say about the topic. So I'm thinking about that constantly, but I don't have a script. It's just coming out the top of my head, unless I have a study to refer to. And then, I may read, excerpts from the study. But yeah, trying to get this done all by myself. It's a challenge, but it's a fun one. And I'm always happy when people make those requests because, at least I feel like I'm doing something that someone wants to hear about and may find helpful. Okay. Any questions for me at this point? I know in the last few episodes I've been coughing too, so I have to deal with that as well. I think the episode that just came out was on insulin resistance, and I hope it was clear to people. The main points I wanted to make is that with insulin resistance, the problem is going to be glucotoxicity and concurrent lipotoxicity. And the reason I emphasize that is a lot of times people just think about the glucose aspects and they don't realize that the fatty acids are very toxic as well. So we tend to be polarized into the carb arena or the fats arena, and your body doesn't do that. It acts as a whole system, and when the balance and the homeostasis goes awry, that's when we get problems, right? So just getting people to understand there's concurrent gluco and lipotoxicity during insulin resistance in your body. And also that it's not just the lack of insulin or inefficient or deficient insulin action, is also glucagon excess that is part of the problem. Okay, anybody who wants to ask a question or just say hello or tell me about your metabolic health if you feel comfortable. Not really? Not yet? I can tell you a little bit about some of the upcoming topics that I'm working on. So there's one on fats that I kind of squeezed in. My schedule has just kind of been really rough very recently, but I managed to squeeze that in. And I will be doing one on resistance training very soon because there's a few of you who requested an episode on that. And just so you know what I'm planning, I wanted it to be a more practical episode than just having a lot of theory, because I think the reason that people requested it is that they wanted something practical to use. Oh, you know what was going on? I was looking at the wrong. I wasn't looking at the comments. I'm still learning how to do this. So hi, Mr. Blue, how are you? Yeah, okay, you were talking about the last video on the last episode that you saw two very interesting things in. I think you put, were those the things you mentioned in your comments? Because I think they had to do with the glycation of the insulin receptor itself, and the glycation of insulin, the molecule itself, and how that contributes to insulin resistance. So yeah, that was something I talked about. And then again, the glucagon issue, which most people ignore when they talk about diabetes or insulin resistance, right? They forget the whole inappropriate glucagon, secretion in the setting of insulin, high insulin as well. All right, yeah, so those are the big ones, plus the lipotoxicity that is going on. Okay, there's a question. I'm trying to figure out. So everybody, please be patient because I'm learning all of this and I have no clue how to do this. There's a new question. Am I seeing this wrongly? There's a question here, but I don't see the question. How does this work? So I'm going to ask Carl, and maybe you can copy and paste the question for me. I can't see the question from LinkedIn, apparently. Is that right? Yeah, I have no clue. So, okay, Mr. Blue, we'll go with you first. Study regarding diets, excessive and insoluble fiber proven to be causative, increasing risk of rheumatoid arthritis. It's not usual for me to make the initial diagnosis of rheumatoid arthritis in my patients, and they may come to me with that diagnosis already. So the causative aspect is always very hard to establish. But, and this was, you said, excessive and insoluble fiber. Okay, so that one I'm not aware of. The general problems have been with soluble fibers, and with soluble fibers, I did mention that there may be issues in terms of upregulation of secondary bile acids with fermentation by gut bacteria, and that might be hepatotoxic, right? So that's one issue with that. I also, have been seeing, and this is particularly in the studies that I have been talking about. They were with inulin, which is a soluble fiber, which means it absorbs water, right? The other thing that concerns me is, in the keto group, a lot of people use those shirataki noodles, right? So that would be glucomannan, and that's from the konjac root. It's a plant source, obviously, and that absorbs a lot of water. It's also a soluble fiber, okay? And people use it to do the shirataki noodles, shirataki rice, right? And I just worry about people overdoing that, because the same issue could happen in terms of upregulation of fermentation of gut bacteria that may then, cause increase in secondary bile acid formation and cause problems in the body, right? So, and you might say, oh, there are all these studies that say that the shirataki noodles or the glucomannan products are fine and that they may actually be good for you and anti-inflammatory and so forth. They said the same thing about inulin. So the huge rush on inulin and people trying to upregulate or increase the colonies of Akkermansia muciniphila in their gut with inulin products, right? Because they read all these wonderful things that can happen. So you see that with the glucomannan now, that there's all these positive things, but we don't know. And as I said, with the gut microbiome, it's not only going to be a specific bacteria, it's going to be an ecology and a specific community, right? The types of species that you have, plus the immune system, plus the actual health and physiology of your gut cells. So with all those things in play, it's really hard to separate out what is important and what is contributing to disease. So I tend to kind of be a little bit reserved with the fibers, and especially the soluble fibers, metabolites of a specific bacteria. Yeah. And the other thing is, these gut metabolites, right? They tend to be very generalized. Whether it's the gut bacteria, they essentially, signal through either short chain fatty acids or these products that will bind to the aryl hydrocarbon receptors. Okay, these are all metabolites of tryptophan metabolism, which is a huge category. Even sorting that out is and that receptor is quite promiscuous. It'll bind to anything. So sorting that out is pretty difficult. Yeah, so that's why I rather take a wait and see with the gut microbiome. Okay. All right. So I was saying the episodes that are going to be coming up, the fats resistance training, and that I'm going to try and make it a more practical episode. So we actually go into what to do and how to do it and the exercises. And I also kind of tailored that for people who are not used to exercise or haven't done a whole lot of resistance training. And also people who may have, maybe confined more to a chair, may have some limitations as to what they can do, right? Because I feel like we have resources for people who are generally fit or even in a very fit category, but we don't have a lot of resources to show people how to start if they're really not very active in the first place. So I'm going to try and gear it that way, but I'm also going to put in components that can dial up those exercises. So, with any of the exercises that I do with my patients, I make sure that you can start in a place that is very accessible, even if you're confined to a wheelchair or whatever. But we want to make sure that there's progression, so I can make it as hard as possible. And, that way you have that range. Maya, how are you doing? And thank you for getting me that article. It did help me. I was preparing for the fats episode, so thank you so much for that. Then besides the resistance training one, I have a list. I will be talking about eventually, not immediately, but next year, early part of next year, I will get to lipoproteins and that whole cholesterol saga that everybody's talking about, and atherosclerosis. Okay, that's a big one. But again, the way I do it, I tend to lead up to the big topic. So if we're aiming for an episode on atherosclerosis, I want to gather all the pieces together so that we can see it, have a nice overview. Because sometimes, again, we dial in too quickly and then the details are fuzzy or we get mixed up. And that's when we start to get into trouble. Okay. Prevotella capri, overcolonize. Thanks for that, Miss Blue. Anytime you have an overgrowth of a species of bacteria or type, several species of bacteria, yeah, you tend to get into trouble. And there's always homeostasis and balance in every tissue, every organ of your body, right? So establishing the balance is not easy because we don't know, what exactly contributes to keeping that balance. Yeah. Okay. And are there topics that you want to hear about? Maya, for example, or Mr. Blue, any one of those, any topics that you've had and you've thought about and, you want me to do an episode on, I'd be happy to. I love anything to do with the immune system and metabolism, obviously, the innate immune system, fats, um, not just as a chemical group, but fatty tissue, adipose tissue, right? I do see a lot of patients with obesity. So I plan to be doing episodes, updates on obesity, but I tend to focus a lot on the fat cell, the adipocytes, because I find them really fascinating and they're so much involved in regulation of metabolism and inflammation as well. Maya said, would you do a podcast on which proteins, animal versus plant-based proteins? Yep. Okay. Protein episode will be in the works. Aging. Do I have one planned on aging? I don't think I had one. Although a lot of the topics that I touch on, they influence aging as well. But definitely want to do one now that you've requested. We got to do one on aging, okay? And first few episodes I focus on body composition, right? I want to go back in because I think I just gave the surface, and there's just so much more in there. Now that you put aging in there, yeah, metabolism and aging have some tie-ins, absolutely, but also regeneration, right? If you think about stem cells, so doing an episode maybe on regenerative medicine, that might be fascinating. Yeah, okay. Maya wants that one too, right? How do we regenerate cells, senescent cells, dying cells, old cells? And I think there's a lot of very interesting work. My tendency for myself in my reading is to look at the data from the molecular and biochemical point of view. But again, I am a clinician, so for me, it's always important to tie it into the practical and clinical aspects, right? So you know all this at a molecular level. How can this be translated into a clinical setting? And maybe you can't do that right now, but what approaches could we take to get us on that path towards some clinical applications of the basic science? So that's really my interest. So yeah, a lot of those topics I will be approaching from that point of view with the molecular stuff, but also bringing in, thinking about the clinical applications so that we can actually be using it on patients. Okay. Aging, protein, got that in there. I think what else I have, had several episodes on fat, not on fat tissue. An episode I just recorded was on, dietary fats, let's say. But on fat tissue, yeah, I could go on for weeks. I think the hard part for me, sometimes I was just talking to Driss, and the hard part is trying to take all this information and distill it down and not clog it up with too many technical details, but also, kind of shine some light on some important points that maybe we haven't considered, right? Supplements for bone and recommended doses for vitamin D, A, K, and magnesium. So yeah, I did talk a little bit about the supplements, a little bit in the bone episode, but we can dial down and talk a little bit more about those specific vitamins and also magnesium as well. And I think I recently saw a study on magnesium and how supplementing them with magnesium, and this time they did a better job. They didn't give people magnesium oxide. They actually gave them magnesium chloride better. And how that actually improved outcomes in, I believe it was type 2 diabetes, right? Which shouldn't surprise them, but somehow, but I'm glad they did that, because that's really important. So yeah, definitely we'll do minerals and vitamins. I think that's a big one. The hard part is also, kind of managing what I enjoy and I'm interested in and what I'm reading. And then also how much foundational stuff do I need to go over so that we can get to the really interesting big topics, right? So, for example, I just did the episode on dietary fats, and I tried to answer the question in the episode because a lot of people ask me, saturated fats and unsaturated and plant and animal sources. And I won't give away the answer, but I find that a lot of these conversations, I don't quite even know how to deal with them or, kind of participate, because a lot of times we're not on the same page. And so when someone's saying something, what do they really mean? Because the terminology is very loose and some of the understanding is also loose. And so it's very hard to have a meaningful conversation. But it's not just those conversations. Looking at some of the studies that people bring up, I'm like, I don't quite know how to read this study because it's got so many confounding factors and so many unknowns. I don't think we can really draw a conclusion from it, right? Which brings me to the point of, again, another conversation that I had with Driss, and that was that, medicine and the research in medicine is, how do I put this delicately? It's been a long week, so I have to put on my diplomacy cap and be extra careful here. But here's the thing. It's not quite the hardest science. And almost all studies that we have in medicine are really observational. Even if we do RCTs and we have an intervention, we just observe the results, So, I mean, if you talk to a physicist and they look at these medical studies, this medical research, and they go, what is this, right? They won't, physicists probably wouldn't consider what people do in medicine as science, really, right? At best, observations, a lot of those studies. So it's real. And then we make these huge, assumptions and conclusions based on these observations. And we don't even realize it's just an observation. And there's so many things that are uncontrolled for. And that is what makes it hard sometimes for me to comment in an intelligent way, because I'm thinking, we're all talking about different things. And how do I answer this question, right? So watch the episode that's going to be coming up on dietary fats. It's episode 10, I believe, because I try to give an example of what I mean by this, right? And that's the whole reason I wanted to do this podcast, was to get all of us on the same page when we're talking about something, so that the discussion can be meaningful and we can move forward in the discussion. A lot of times we get stuck because really we're talking about different things, and it's not going to be very productive that way. Okay, so getting people on the same page is a huge goal for me in the podcast. And then they have reverse age in adults by 3 years through the methylation measurement. Okay, I hadn't, through diet and exercise. If you could do aging and possibly explain how true age can be measured, and it's possible to improve telomeres. Yeah. I definitely will try to look up the study that you mentioned. And true age, how true age is measured. Again, this is going to be a compilation of different biomarkers that people think are important, and maybe performance-based or functional-based sort of things that, we measure in people, grip strength and how well they can balance and move, that kind of thing. And then we kind of approximate an age with that. I don't think we have gotten to the point where we can actually pinpoint, a biological age. We try. And, in the context of the entire body, that's going to be very hard to do. So rather than age, you hear people focus on health span. And the idea of a health span is, look, it doesn't matter how long you live, you want to be healthy for as much of the time you're here as possible. So, you hope that 99.99999% of the time that you're alive, you're vibrant and healthy, right? And that you can do all the things you want to do and enjoy life, the way you want to. So thinking of a health span is more useful, I think, that way. And how do we optimize and maximize the health span, I think, is a better way than thinking about, longevity, because that implies just pure time, extending the time. And with the health span, you want to extend the quality of life and the health aspects for as long as possible, So I tend to prefer to focus on health span rather than just pure lifespan. So, but definitely when we talk about aging, those are lots of things that I'll go into. And I'm also planning one on, and it's not one, it's going to be a series on movement, because as a mover myself and as a dancer, just very interested in movement and cognition, movement and the brain. So definitely would like to have a few guests on to participate in those episodes. And a lot of the guests that I have been kind of preparing to invite and talk to, a lot of them are amazing basic scientists who are, many of them, leading experts in their field, right? And I just find that it's really fascinating when you get that perspective from someone who's doing the hard science and has really a huge knowledge base on that particular aspect. Okay, and so that should be fun, and that's what I'm planning for a lot of the guests that I want to invite. Okay, so movement, and I told you the atherosclerosis and lipoproteins. And lipoproteins, everybody talks about cholesterol. Sure, it's very important. There are so many other fascinating aspects of lipoprotein that I hope to highlight and get people to think about. And it will actually be important when we think about atherosclerosis, right? But everybody just focus on the cholesterol. Even the people who don't support the cholesterol, hypothesis are focusing on the cholesterol. They are hell-bent on proving it wrong too, So there's a camp that's hell-bent on proving it right, and there's a camp that's hell-bent on proving it wrong. Both have in common that they are focused on just the cholesterol, right? So there are so many other aspects that we could focus on that might be interesting. It might be worthwhile for us to consider. I just always like to have a broad overview and think through, and I like a systems approach, right? So a lot of what I read, it may be hard science. It's very specific to one part of your body or one particular mechanism. But then at the end of that, I need to step back and look at the whole picture and try to put together a systems approach to this, because nothing occurs in isolation, nothing. And it's always going to be impacted by, that specific context. The other thing that I want to highlight here while I have you guys here today is that a lot of the things we talk about in medicine are going to address a systemic approach, right? So, and generally we mean that what is dispersed and is happening through the bloodstream, right? So we're connecting the body through the circulation, through the bloodstream, and it's a systemic approach. So when we look at hormones, they may be secreted in a particular part of the body, but the effects are going to be throughout the whole body systemically, because they're carried through the blood to other parts of the body, and they have their effects on different tissues and organs. Okay, but I think a huge part of what we miss in medicine, and that we're still not teaching in the medical school curriculum enough and emphasizing enough, would be, instead of this huge systemic view, the local view, the paracrine and the autocrine views. In other words, what's happening within an organ or a tissue in neighboring cells, or in this one cell as it signals possibly to itself, or signals to itself and a few other cells around it. The paracrine and autocrine effects of cells and local tissue is huge, has huge impact, right? And I make that point a little bit in the episode I just filmed, the one on dietary fats. Because when we talk about, the effects of, let's say, prostaglandins and stuff, it's going to be very specific to tissue, right? What tissue are you talking about? In what context? And you can't always say it's inflammatory. Okay? Skin. Ooh. Skin is a fascinating organ. That's a great suggestion. I never thought of it. Wow, you're a gem. I'm going to put skin on the list. It is a fascinating organ, really, and its connection to the brain, right? And and the presence of not only, you have skin microbiome, but you also have all those dendritic cells and the tissue-resident macrophages and immune cells in that area. So skin would be awesome to talk about. Thank you. I'm going to definitely put that on the list. Very excited about fat. Very excited about fat. And every time I read something about fat, I go, ooh, fat tissue, right? And then I'm like, oh, okay. Like, I have to wait to get to it. And I don't know, maybe I'm thinking this through, that maybe instead of trying to just build everything up slowly, just go sometimes and do it, maybe not necessarily in a consecutive episode kind of approach. Just kind of sprinkle them in and eventually get to where I want to go to. I don't know. I'm trying to work out my approach here as well, because, like I said, there's so many exciting things to talk about, and yet I've kind of gone very slowly, because I've just thought, to make this interesting and to make this productive, let's at least all get on the same page. So when we're talking, we understand that we're talking about this specific context, because a lot of these conversations, I can't stress enough, a lot of these conversations, they get very confusing because we're dragging in aspects of other, other things, and it's getting very mixed up and fuzzy. And for this reason, we don't really have a chance to have a meaningful context for the conversation, right? So that's why I kind of slowed it down and went that route, But there are so many like really exciting things that I want to talk about. Fat, skin, now that we're talking about that, right? Sickness behaviors, fascinated by sickness behaviors for a very long time. And I was recently sick, and the whole time I was sick, I was taking notes. I was like, oh, interesting. Because, at one point I lost my appetite, but I was starving. I was hungry. I was really, really hungry. I had no appetite. And, I ended up making myself eat anyway, because I was like, oh, this is a catabolic crisis. You have to eat. And so I kind of thought about it, maybe too much, and then worked out what I wanted to do. But sickness behaviors are fascinating, and they have a lot to do with the immune system, obviously, and this balancing out of the immune system and metabolism as well. So at least one whole episode on sickness behaviors and fuel partitioning in different types of sickness. Okay, so different infections may result in different fuel partitioning, and this is really important if you are, let's say, treating someone in the ICU, because a lot of times patients in the ICU, they're on a ventilator, and you have to provide their nutrition through TPN, right, IV, and you give them nutrition that way. But if you are not providing the right nutrients, you might be working against your patient, right? Because the partitioning of fuel and nutrients during, let's say, sepsis is very important. And you gotta have to figure out whether you're using the right thing or not, right? So that's another topic that I have been fascinated by for a long time. I also want to mention, I did do a very general overview on macrophages. It's, if you look on YouTube and put in the search bar, Magical Mystery Macrophage Tour, and macrophage is MACROPHAGE. If you put that on, you'll find that video, and it's a general overview on macrophages, but I only did, because I only had an hour, one tiny corner, like, okay, this tiny corner here, this one, yeah, tiny corner on macrophages. And there's so many other aspects of macrophages. It would blow your mind if we went into them, because all the time I'm reading about macrophages, I was like, oh my God, I have to do an episode on this. I have to, so macrophages are always going to be top of my mind, really. And yeah, Maya, I know you're interested in nutrition. So different nutritional needs with different illnesses. We don't know a whole lot, but and most of the models we have are still animal models, mice models, but very interesting with different infections. What different nutrients will do. In some cases, it will be lethal, and in some cases, it will be helpful, right? So that really opened up my eyes as well. Again, ICU, nutrition is basically TPN, and it's based on your guesstimation of caloric needs, and then X amount of this, X amount of proteins and fats and glucose and that kind of stuff. It's kind of and then put the electrolytes in and put some minerals on board, that kind of stuff. But it's really not looking at fuel partitioning, because we've never had that kind of information before. But looking at the basic science, I'm hoping we will have more studies that eventually will extend into into humans. And I don't know if that's easy to do, though, but it would be very interesting to see, because definitely in the animal models, you will see a difference depending on what fuel you provide, right? So sickness behaviors, big category. Other things that I've thought of that I'm going to be talking about eventually. So just your basic chronic diseases, right? Like things like hypertension. And it seems like such a basic topic, but when you go into hypertension, you could probably extend it into several episodes, because there's so many aspects to consider with hypertension. So, and definitely would like to start looking at that. Want to look at the renin-angiotensin-aldosterone system and how that affects your body systemically and, again, locally in tissue, which again has been ignored a lot, right? I have for many years been fascinated by the renin-angiotensin-aldosterone system in the brain. So brain tissue actually expresses RAS, renin-angiotensin-aldosterone system, so RAS, RAAS. Brain tissue expresses RAS proteins greatly, and very interesting to kind of consider that, but that's never been really looked at, I think, from a clinical aspect. We tend to just think of RAS in a systemic aspect, and for blood pressure management. But the RAS system is a huge system for generation of inflammation through reactive oxidant species, right? So systemically, obviously, but in all tissue, and most tissues have RAS in them, but the brain one is very fascinating to me. And some of these feedback loops that you see with RAS, I think this is the part that kind of blows my mind. Some of these feedback loops are not negative feedback loops, which is what we normally see in nature. The positive feedback loops. Okay, that's pretty scary, because it's now going to augment the effect of the RAS. It's instead of controlling, having a homeostatic control, with augmenting the response, and that's pretty scary to me. How much nutritional information abandoned, lost, forgotten? Yeah, I mean, and a lot of nutritional compounds, they're kind of ignored until we can make it in a pill, and suddenly pharma will be interested and they'll do some studies on it, right? And then suddenly it's good for you, suddenly it's not good for you, that kind of stuff, and there's so many mixed pieces of information. I don't even know if they're real information, because some of it is fuzzy or inaccurate, and so you kind of worry about that as well. And like I said in the last episode that I just filmed, the episode 10, I tried to address it. I don't have all the answers, but I at least want people to see, okay, this is a problem, right? What is the study saying? Nothing that we can understand, because we can't agree about what we're really talking about. But here's the worst thing. We don't know that we're talking about possibly very different things. We don't even really know that. We don't recognize that. But then we kind of, march out this study and we proclaim its results as if they had some real value. And I'm just like, I don't know about that. So I'm just asking us to kind of pause and think and ask the question, are we talking about the same thing? Do we even know what we're talking about? What are we actually saying, right, when we say X? So it's pretty basic. Maya, in a biostats course or something, study designs, you should be asking those questions. But again, I think in medicine, we're not really scientific. At best, most studies in medicine are observational, if we were really honest with ourselves, right? But yeah, sadly, we like to push the whole science bit, and we don't really have that very much. Okay, I mean, and that's why I like the molecular approach. I like the biochemical approach, because at least that I can understand and see those pathways. Okay, and based on that, you can think your way through certain things, right? So just as an example, these nicotinamide supplements became very popular at one point in time, believed to be anti-aging and seemed to have some anti-aging effects. And I was thinking about this and looking at the metabolism. I'm thinking about cancer metabolism. And I was like, I don't know if that's such a good thing to be supplementing this in high doses, right? It might not be good for everyone. Again, context. So I was like, I don't know. So I never actually jumped on that bandwagon, and I didn't really recommend it, right? And then, recently I get this deluge of questions from people about those nicotinamide supplements and how they've been linked to cancer, and is that possible? If you look from the metabolism point of view, you could, you should have seen this coming, the possibility of that happening. Again, I'm not saying it's causative, but you at least see down the road and you go, don't know. and very context specific, right? So you got to think through, is it going to be appropriate in this patient? And a lot of times you don't know, right? When you start a medication, even on a patient, you don't know for sure how a patient will respond. And, with a lot of these situations, I'm always thinking through the context, this patient and in this tissue, right? This overall picture, and where this patient is in the lifespan, and the context of other medications and other medical problems, and then you kind of have to make some guesses. It's not an exact science, but that's really what we should be doing with every patient. Unfortunately, the way these medical appointments are going, they don't have time. Nobody gives you any time. It's just click, 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 and it's more to justify some checklists that will keep the insurance companies happy. Uh, they don't really care if you did anything. If you check the boxes, they're happy. Did you actually help the patient? Who cares? Okay, lady, just check the box, okay? And then maybe we'll pay you. So they're not really motivated. Oh, but wouldn't it be to their benefit if the patient got better? It seems that way, but it's not always the case. It might surprise you. A lot of these insurance executives will tell you to your face, they go, listen, the thing is, most employers who buy the insurance for their staff, they do this and then they change insurance plans very quickly. Every year, every 2 years, they might switch to a different plan. And the reason for it is, oh, that's cheaper, we'll go with them. All right. Oh, this year, this one's cheaper, so we switch. So every year they kind of switch around. So if you're an insurance executive, think this through. You're paying for preventive care, and then you get someone healthier, right? You should be able to reap the benefits, except now they switch to another insurance company, and you just spent this money to get this person well, and you don't reap the benefits, right? Because that person just went to another insurance company, and that company will be happy, hopefully. Now, obviously, we can see that if we all collaboratively did that and the whole pool of patients got healthier, that would be a great thing. But no, it's always very short term. What's happening this year, next year, right? End of year, got to make those financial numbers look great. So that's kind of how it goes, right? So that's why they don't want to give you the time, and it's not necessary to have a meaningful visit. It is, let me just underline that. It is not necessary to have a meaningful visit from their point of view. Just check the damn boxes. Okay, we're done, right? And so I hate to say that, but after all these years being, we all start off wanting to do our best to help people. And then you find out the system's rigged. Now, then you spend the rest of the time wrestling with your conscience and your own value system, right? And negotiating your own disappointments, right? And then going to work and doing something you don't believe in, right? And then they wonder why you're burned out. These physicians, they're burnt out. Why? And I'm like, oh God, I don't even want to go there, because I'm sure they are relatively bright people and they understand this, but maybe they just don't want to see this, right? Yeah. Yeah. So back to the supplements, it's, I do use supplements on my patients, but you can bet I think it through a million times. And I'm looking at that context, and I'm thinking a gazillion times, right? So for example, again, just because I just finished an hour before I got on here on the live Q&A, I just finished taping that whole dietary fats episode, that whole EPA, DHA thing, right? These PUFAs, the polyunsaturated fatty acids. And everywhere you look, it's cardioprotective and prevents you, from having irregular heart rate and everything. It's like, well, okay, I don't know, because there's at least 4 studies. Okay, one of them, yeah, there's at least 4 studies that seem to suggest, and I don't know, seem to suggest that EPA somehow is associated with increased risk for atrial fibrillation. Okay, so should all your heart patients be on high dose EPA? Actually, I'll be very honest, my AFib patients, I have been very careful. You could give DHA. I didn't say this in the podcast, but there's some retro conversion. So if you just give DHA, you can make some EPA, right? But giving EPA in the context of atrial fibrillation, especially paroxysmal, meaning that they go in and out of AFib, I don't know. So I'm at least very careful if I don't know, because I know what I don't know, and then I back off a little bit and at least try to figure out and read more. Okay. Oh, hi, Thierry. Read that recent study, fish oil could cause heart problems. Yeah. So that was with EPA, right? DHA tends to be more for brain, neural tissue, eye, very important for the retina, sperm. So DHA is different. And like I said, I was saying there's some retro conversion. So you kind of could get away with it by giving DHA supplements. And then there's a little bit of retro conversion to EPA from DHA. So sometimes I will take that route. Okay. But again, before you do that, you kind of thinking through the context and what is this? What am I seeing in front of me? This particular patient, this context. Do you put everybody on fish oil? Or if you want more of the omega-3s, here are your different ways of doing it, and how are you going to optimize for this patient, right? So in the case of someone with atrial fibrillation, I may optimize omega-3s again by DHA supplementation that way, and so that you're not actually loaded, and that retro conversion is a small rate, decent but small rate, and you're not loading heavily with the fish oil supplements. The EPA has some mild inflammatory effects as well, and we've known for a long time that EPA seems to be associated with increased tachycardia in people. So whether that's linked to the arrhythmia, don't know, right? But I've always known that there's this correlation with tachycardia and increased dosing on the fish oil. So, possibilities, right? Yeah, and pregnancy. Oh, okay. So yeah, about the, so a couple of things. You might need to cut back on your fish oils. Yeah, again, it's context. Okay, it's very, very much context. If you have an eye issue, macular degeneration, I don't know, you might think through some of it with your specialist, right? And which omega-3s are you going to preferentially put on board? Are you going to be focusing on the EPA or the DHA? If it's eye, I would prioritize the DHA, that kind of thing. So you want to think that through, okay, and figure out how you're going to give that dose. But with the OBGYN thing, I have a very good friend from med school, and she's OBGYN. So I plan to have her as a guest as well, because we want to talk about, how do you take care of yourself during pregnancy, right? Take care of yourself and your growing baby during pregnancy, and also postpartum, right? And what are some of the concerns in terms of fertility, right? Getting pregnant. So all these things are really important. Nutrition during pregnancy, that is a huge black hole. There's some recommendations, make sure you get your folate and this and that are very general, but I still feel like there's big holes there for recommendations in pregnancy, and we don't have a lot of studies to kind of back us up in human studies, right? So we may have animal studies, and then you don't know what to do with some of that. So that's a bit of a problem, but definitely having someone come as a guest to do OBGYN would be huge. And then looking at some of the, let's say, reproductive cancers for women, because again, that has been a problem. And, we have to figure out, how we can optimize the health. PCOS, PCOS, infertility, how to take care of ourselves during the menstrual cycle. That's an interesting one. Yeah. And, the regulation of hormones, right? Homeostasis with that. Even thinking about the regenerative ability of the uterus post-menstruation. If you talk about regeneration, regenerative medicine, that's a very interesting one to consider. So those are all great topics. I'm glad that you guys are bringing so many ideas to me. Like I said, I'm going to have to kind of inch into these because the content is just me, and I do read a lot in and out in between patients. I'm running back and forth. And if I'm preparing an episode, I'm just in my head thinking of how to organize it. I just have scraps of paper that are like little points, bullet points. Don't forget to say this. Oh, don't forget to mention this, So I don't have a script, and I'm just going off at the top of my head. And sometimes you had a long day, and now it's like 10 o'clock at night, and you got to get all this information and try not to do too many takes because it's tiring. Yeah, so, trying to work through that, it has been certainly a big challenge for me. And like I said, Maya, thank you for your help. And getting articles is very difficult sometimes because, like I said, I don't often have access to all those articles that I may want to access, and I do read quite a bit. So I usually have to beg someone to get them for me, and that in itself takes time. Okay. All right. So we're coming up on the hour, and I just want to say a big thank you for joining me this evening. I will be having these sessions roughly every 2 weeks. If you go on my website, you'll see the schedule, VyvyyaneLoh.md.com. It's coming right across the banner right now, right? So that's the website. So look under events, and that should give you the dates. And in the next month, I think that I'm going to prioritize a Friday, just trying to work with my schedule, but also hopefully other people's schedules. Sometimes Friday evenings might be an easier time. Again, if you're listening in, please let me know what are good times if you want to attend these live Q&As. If you want to kind of, bring your questions to me personally on these Q&As, okay? So, but roughly, I'm trying to do it every 2 weeks, and probably next month it'll be on Fridays. Explaining these. Okay, you know what? Thank you for saying that, Jia, because I have no clue. I'm like, is this helpful to people? Do people get anything out of this? And I think it's good, I mean, like, I think it's maybe useful information, but I don't know. So when you tell me, I go, okay, all right. If that's more of what you want, and I can, we can go anyway. And also, I have a lot of interests, and when I am board certified in internal medicine, so that's how I see it. The entire body is of interest to me. And if you have a particular interest in one area, or you have a disease that you're trying to understand, you went and you got diagnosed, and something about your kidney and what's going on, so send me a request, right? And because I do that for my patients. They get a diagnosis, they often don't understand what it means, and then I sit and try and break it down so that it's meaningful. I don't want to dumb it down. I want them to understand enough so they understand what the doctor is worried about and what overall we have to work together to get to. So you got to have some complexity in there, but they have to be able to understand it without a whole med school education, right? So that's the part that can sometimes be challenging. So yes, thank you for that. And I definitely will focus more on making sure that it's easily understandable by lay people, but not dumbing it down. I hate dumbing things down. Okay. So thank you so much again for joining me. I will see you, hopefully all of you, in 2 weeks on a Friday. Okay, and bring more questions and bring more topics for me. All right. Until then, take care. I'm going to give you a big air hug. Bye. Okay.